actually one of the sessions that I'm most excited about for this year's summit. It is with my friend and colleague of several years now, Tom Montgomery, who's the founder of Civic Health. And she's going to be talking to us today about how we can think of ourselves and claim our power as health citizens. And so what we're going to do is Tara is going to sort of do a presentation for about 15 or 20 minutes based on an article that she published last year that I read and loved. And then I'm going to come back, and with all of you great folks in the chat room, we're going to have more of a discussion and then just sort of a straight up Q&A. So I'm going to turn it over to Tara, and she's going to do her presentation, and we will be back in maybe 15 or 20 minutes to have a conversation with all of you. So take it away, Tara.
Hi, everyone. It's good to be here. Since I'm the last speaker, let me just give some credit to Christian and Kate and Bernie and the team for running a fantastic virtual conference, testing new technology, rolling with the hiccups. I've learned so much from all of you, and so I'm really pleased to have the role of wrapping up and talking to Christian again at the end. So I'm going to flip over to my slides and talk through those for a while, and then we'll come back with our faces on screen in 15 minutes. So my name's Tom Montgomery. I'll give you a little bit of background about who I am. So I actually led health at Consumer Reports for about 15 years and worked with several of you, including Christian, through the Safe Patient Project led by Lisa McGiffert. And in that capacity, really got to hear the stories of patient advocates and people who had dealt with C. diff and other hospital-acquired infections, and really joined you not only as a strategist but as an ally. From there, I set up my own consulting firm, Civic Health Partners, where I work with health leaders around the country to help them reflect on how to earn the public trust. And that means really through sort of changing their actions in a really foundational way, and then communicating more effectively and authentically with the public and with their constituents so that trust can be built in ways that lead to better outcomes for everybody. I have a few other disclosures. Most of my clients, collaborators, and so on are nonprofit. And so I don't take money from industry or any special interests. I really just try and advise people who are trying to do the right thing for patients. So yes, as Christian mentioned, I wrote an article for the BMJ in December of last year. And that article was called Claiming Our Power as Health Citizens in the Age of Overdiagnosis. And that's really the launch pad for this presentation. So why did I write this article, and why do I care about the issue of claiming our power as health citizens? I come from a communications background and work on strategy. And, like many of you who have worked on advocacy for a while, you really have to think about how to frame an issue and how the language really makes a difference to how people hear you and what kind of results you get. So there are the words we use in our campaigns that we may test, our messages, but we often don't really reflect on what words we use to describe ourselves. And those words are not only meaningful to our audience, but they help us feel what our role is in the change that we're trying to make. How we show up and identify ourselves really impacts how other people see us, how they hear us. And when we choose the words that help us claim our power, we're really going to achieve that kind of power. So with that in mind, I started to think about the words we use as advocates. Sometimes we say we're patient safety advocates or consumer advocates or just advocates or something else. We've got a poll, I don't know if it's up and running yet, that will allow you to comment on how you identify and what kind of roles you believe help you achieve power. So if that poll goes up, you should flip over and take a look. So I'm going to start by reflecting on the different categories that we often use and maybe critique them a little, because where I'm going is to really challenge us to consider ourselves as citizens of health. So, you know, by default, most of us are seen as patients in the world, or the survivors or families or caregivers of patients. But when we say we're patients, that can be true. We can be in a critical situation where we need the support of the healthcare system, and that's, of course, completely necessary and legitimate. But so often, our culture, especially in America, kind of medicalizes us all the time, so that patients are the body of people who are not physicians and not industry. So that can be a problem, where we begin to feel that it's normal to be sick, normal to have the label of a diagnosis. And really, we might, even with a label of a diagnosis, want to see ourselves as people who are well and entitled to be well, and that we also live with something that makes us patients, but that doesn't define us. The problem with patients historically, as a lot of you know, is that we are sort of expected to be passive. And of course, there's a lot of work to build up the idea of an empowered patient and an expert patient. But really, that's very early. Most people don't believe that patients are experts in themselves or experts in the issues that we deal with. And that helps us kind of behave a certain way in our relationships with the healthcare system, where we allow experts to make decisions about us without us. We feel separate from the system that's caring for us. We don't feel it belongs to us. And, you know, as you've probably heard, the double meaning of patient, like we're expected to be patient. We're expected to accept the system and trust the system. So that role kind of sets us up to behave a certain way in our relationships with the system and our behavior as advocates. So I sometimes question that. But at the end, I want to talk about when that can also be useful, because it's not that it's not useful, it's that it might not be enough. Then, you know, I came from Consumer Reports. We talked about ourselves as consumer advocates all the time. And often in the health system in America, we describe advocates as consumers and members of the health system as consumers. And that's such a uniquely American thing, of course. You know, you can hear my accent. I'm half British, so I think about this a lot. We're members of a market system in the US, which is not the same as most other systems, of course. But when we're in a market, just like any market, buying cars or anything else, our relationships become transactional. We're very aware of who is making money from us and the fact that that's their motive. It's very hard for them to set that aside and put our interests first beyond the financial aspects of that. There's also the idea that consumers are rational beings in an economic system, and that we, you know, weigh the costs and benefits of things and make decisions that are not, you know, full of emotion and complexity, which is the truth about health. Health is really one of the few consumer areas where emotions often drive our decision making and drive our communications. So it's kind of unreasonable in that context to imagine that we can behave as these rational consumers. And if we were required to behave like that, then we need the tools that other kinds of consumers have in the world, that we have for cars and everything else, where we have tests of quality, rigorous, transparent data about that. We understand safety issues and the safety record of a provider or a product or service. And we have clarity around the cost, how much it will cost us, how much it will cost the system. And all of that is so lacking still in the US. So even when we want to behave as consumers, we're failing. Now, another big problem with the term consumers is that we become part of this culture of overconsumption, which has an impact on sustainability. It has an impact on equity in our country. And particularly, it leads to overuse of unnecessary health services. So as advocates for C. diff, you know this well, that overuse of antibiotics leads to C. diff or hospital-acquired or healthcare-acquired infections. And this culture of being consumers drives us more into that space of being at risk of those kinds of harms from overuse of healthcare. So with that framing of us being consumers, our safety and well-being are not the priorities for the leaders, the powerful people in the system. And that's something that I think needs to change. And of course, we can talk about when it's useful to be a consumer, because sometimes there is power in your pocketbook. But again, that's not enough. Then we look at what it means to be the public. So we have the government and industry and so on, and then this very abstract notion of something called the public, that public is kept at arm's length from all power, from policy, from practice. Instead, we're kind of left as targets of media and public relations efforts. There's a difference between what it means to be in the public and what happens in private, and we're not in those rooms, and we don't have the credentials to be in those rooms. We don't have the control over resources that is happening in those rooms. The public is just sort of this, very vague thing that is considered orderly and compliant in our culture and our society. Where, by default, we're expected to have trust in the institutions that have power over us, and not to really be a part of owning those institutions. And then lastly, as the public, that isn't a tangible thing. We don't have a collective voice. We have platforms to use our voice, but really that's not an organized kind of voice of the public, if there even is such a thing as the public, because we're a lot more diverse than one thing. The public is never sort of segmented the way it needs to be responsive to our different needs. So then I imagine our role as citizens and really borrow from political science and the ideals of what citizenship should be. So not the problematic version of being a citizen that's tied to immigration debates and legal status. I'm not talking about that. I'm not being too literal. But if we think about the origins of what citizenship was meant to be, it's part of owning a democracy. And again, in the US, where our healthcare system isn't owned by the people in the way it might be, say, in Britain, where the National Health Service really is, and people have that sentiment about it. We need to really shift in the US if we want to believe that we're citizens of our healthcare system, or if we want to demand that we become that. But when we become that, we have a lot more power. We get to participate in co-creating that system, in stewarding it. We get to provide the input into the priorities of that system and to advocate for the public good within it. We get to fight for the systems that actually work for us collectively and individually. So we get to understand our role as participants with that citizenship lens. Again, as citizens, if you imagine the kind of bigger systemic issues in the country, we get to recognize that health is interdependent with other policies, with other things to do with education, finance, housing, all those social determinants of health. As citizens, we vote about all of those things, and health is connected to those things. And then our values and preferences as citizens, as they are with us as voters, become centered. So in our ideal world of citizenship in health, we can start to trust because we're part of a system and we're part of making it and ourselves accountable. That's a time when transparency and truth can show up, where they're missing in other contexts when we're just seen as the public or the outsiders. And all the rights that we have as citizens can be utilized, can be leveraged in our work as health advocates and our work to improve the health system. Those are our social rights. They are our consumer rights, but our privacy rights and more. And then we can use our voices as citizens to advocate for our needs to be met and recognize that our problems are rooted in the bigger systemic challenges in our country. Because as citizens, if we imagine the future that is better than now, we believe in progress, and we know that we're assets and not liabilities in the system. So there's sort of a social identity theory at work here, which is something that where we think about ourselves as either insiders or outsiders in the system. And often when we're advocates, we're seen as outsiders who are coming in to disrupt. And that can be a brilliant thing. It can be a needed thing. But outsiders are often not considered to be assets. So what happens when we claim that entitlement, that we are assets in our country and we're assets in our healthcare system and we're assets on behalf of the people who have been harmed by the healthcare system? And I think when we feel that identity and feel a little bit more entitled to advocate, we have the confidence to go in and make change. And that's where we really get to own our power and not feel that we're asking permission to own it. So those are my thoughts on what it means to be a citizen in healthcare. And I know it's not something everyone will accept, and our identities are complex and we have multiple identities. And that's something that I wanted to really explore in our polls, which are up now. So I'd love to know how all of us feel about our roles and whether those are multiple identities. And then I want to call back Christian to have a conversation about some of these topics on the slides. So what identities give us power in our patient safety advocacy work? What does it mean to use our patient voice, our consumer voice, or our citizen voice? What are the pros and cons of advocating for change as outsiders or insiders? Or can we do both? What are the big systemic challenges that link together the problems that we're working on? So C. diff, antibiotic resistance, and now COVID-19. And I know a question came up earlier, like how can we leverage work to change policy there to so I'm going to come back. Stop. How can we leverage work to change policy there to Hello.
Hello.
How, but it's gone.
We had a little bit of a hiccup there at the end. So awesome. I am really excited to talk to you about this and to have other folks participate through the chat. So, this is something, and I'll just start off by saying that, this is something that I've been obsessed with even back when you were working at Consumer Reports. I think you might remember being at a patient advocate summit with all of us from all different walks of patient advocacy, and me taking umbrage at being considered a consumer. And I understand where Consumer Reports was coming from, but to me that was too reductive, right? And I felt, we've been talking about this over the last 3 days, that tax dollars going to Medicare and Medicaid, nonprofit status for hospitals and nursing homes. Like, there are many, many ways in which our healthcare system is quite reliant on sort of the public funding of our healthcare system. And so my feeling is, we really need, not only do we need, but we deserve to have a much bigger voice in this as citizens, right? And I think it's something that we can't wait until we need healthcare to have that voice. We have to kind of have that shared voice of solidarity. And I think something that we're seeing with COVID-19, and I'm curious what you think about this, but is this enormous solidarity, right? Those of us who are not in a high-risk group per se, we are more or less staying at home because we don't want to overrun the hospitals. We don't want to transmit this infection to people who have a higher likelihood of a bad outcome or complications. And so I've been thinking, over the last 5 weeks, because I've been in my house, when I've been planning this, I've been thinking to myself, do we have greater sort of solidarity around healthcare on the other side of this, and a solidarity that crosses identities, right? Because I think, like, as a queer person, like, I have a lot of solidarity with HIV positive people, even though I'm not HIV positive, just because of the history of how that disease came to this country. Mm-hmm. So, I mean, are you hopeful around that kind of solidarity?
Yes, I think what we're seeing, and we don't know if this will sustain, but people are starting to come around to the idea that we need a more integrated health system. And there's solidarity around taking care of each other in a way that has been missing for a long time, where every issue in healthcare is considered a niche issue. And if you're not personally impacted, you don't have solidarity, you don't share responsibility, you don't share the fear. So I think that COVID-19, which is an absolute tragedy, is amplifying the kinds of things you've been working on for decades. I mean, in HIV/AIDS activism and in C. diff activism, to say we need the whole healthcare system to improve and take care of everyone, because the impact on everyone is adverse. Even if you're not the one person that gets that disease or that infection, there is an impact across society on that. And I think you can be in denial about the rare diseases and the things that you haven't heard of. C. diff still sometimes has that problem. When there's visibility and prevalence of a thing, then everyone wants something to change, and everyone says, what's wrong with our system? And they're not saying what's wrong with our response to COVID. They're saying what's wrong with our system, what's wrong with our country. Mm-hmm. And so there are conversations about how to pay for healthcare again, about data transparency and reporting, which is something you had a great presentation on earlier in the week around death certificates. I mean, death certificates alone are an issue with COVID, of course. So all of that public reporting, people are saying, where's the data? Where's the data? Why are people dying while we don't have the data? That's what you've been saying in C. diff
for a very long time.
So that's where I think we need to always be advocates for each other. It's sort of like the intersectionality idea in other areas of change, that when infections advocates speak up and support COVID policy, then maybe the reverse will happen. But it's good for all of us when we ask for the big changes, because our system is set up to fail us. So when we're citizens, we can see that big picture. As individuals, we have loss around a particular infection. We have stories that make me cry from your community, this community. And we don't need to stop talking about those individual stories, but there are big lessons and big picture things we can work on as well.
Yeah, I mean, one of the things that comes to mind, and we have a couple of comments that we can go on to address, but I would just say this, is that, you know, when this thing first happened, and particularly we started seeing deaths in the US, the first thing that came to mind for me around COVID was, like, I know the experience of having a loved one become gravely ill, going to the hospital, having them die very quickly, and having never heard of the thing that killed them until that moment of diagnosis. And, you know, if you're not somebody who pays a lot of attention to the news, you might have been that with COVID. You know, oh, I thought that person had the flu. I thought they had a bad bronchitis. And instead they have this really new disease that none of us had ever seen before January or December. So, you know, that was a strong reminder to me of, like, why we do this work. So Bill says, are you in contact at all with American Healthcare Association, the trade association for nursing home and assisted living operators? I am not in particular. We have in the past, I've been on panels with the American Hospital, with people from the American Hospital Association, particularly their government affairs people. And, like, I don't want to, speak badly about them. They're doing their job in terms of representing the interests of hospitals. But what I would say is that the interests of hospitals and executives at hospitals are not the interests of patients. And so we have been on the other side of certain issues with the American Hospital Association. And frankly, during this entire COVID-19 crisis, I've been surprised that we have not seen more of them, like the head of the AHA or the head of the AHCA that Bill brings up, out there sort of publicly speaking about what's going on in their facilities and the help that they need. I mean, I suspect they're lobbying behind the scenes, but I think the public could use to hear, a collective voice from our hospitals right now.
Yeah, I'll add on the trade association overseeing nursing homes and assisted living and that whole industry. I mean, that's a very broken industry. And, a lot of the infections we work on are outbreaks in those kinds of facilities, and COVID as well. And, we need to be better at rating the quality of those facilities. We need to, importantly, pay the people who work there better, because those are seriously underfunded places where the very people who work there are themselves vulnerable. And they're dysfunctional institutions. And we often talk about hospitals and not nursing homes and other facilities. Those feel way less accountable, and tragedies are happening in them. And I think that's another citizen opportunity for us to talk about how to improve that system and resource that system, because those are not bad people necessarily leading those places. Those are underfunded places. And so what kind of work can we do to improve quality, to lobby to get the funding to improve quality? Because there's an impact for all infections when we do that kind of advocacy.
I agree 100%. I mean, I think I mentioned this in a different conversation yesterday with, we had a bad experience in the last couple of weeks of my grandmother, Peggy, my mother's mother, of her life, where she was in a nursing home. And, we were there every day. I mean, it's not like it was now where people can't even access their loved one in a nursing home, which makes me incredibly nervous. And where they're dealing with, underpaid staff, undertrained staff who are themselves at risk for getting and spreading coronavirus. When she had a bad outcome where she had a stroke and no one, I don't know if they didn't notice, which seems impossible to believe, but they didn't tell us. And it was only when we recognized it that, the saddest part is that she was in a good nursing home. Like that was what was happening at a place that had reasonably good ratings. So Helen asked, you didn't mention Press-Ganey scores, which can hold some health systems accountable, or do they not do that?
Yes.
I don't know anything about that. I'll just refer that to you.
There are the Press-Ganey scores. There are the Leapfrog group scores, which I have been involved in to disclose, and others, Consumers Checkbook. There are groups doing, which you might call consumer groups, because they often come from the place of purchasers saying, we won't put our money into institutions that are failing. Those scores do hold people accountable, sure, especially if they get publicized. I think those scores are leverage for us as citizens and advocates to say we know. They're only the tip of the iceberg, though. I mean, Press-Ganey, I think, focuses mostly on experience, not outcomes and not process. Leapfrog is a little broader in measuring quality and safety of health institutions. Those are tools for us, but also they're not federally mandated. So even though they are respectable, reliable scores, they're a piece of the puzzle, but they'd be a lot more powerful if they were required. And that's something that, again, we could be lobbying for and saying this needs to be systematic and not a private enterprise. So that would be my response on that.
I think that, where Leapfrog is concerned, they're, and if folks are not familiar, you should definitely Google the Leapfrog group and look at, they rank hospitals, and I think they started to move into nursing homes as well, or maybe outpatient surgical sites. I know that they were expanding. Um, and so, we had worked successfully with them. I mentioned earlier during Kevin McDermott's presentation around holding back the attempt to eliminate some quality measures that included C. diff and other infection reporting through the Centers for Medicare and Medicaid. And so Leapfrog is good. They are something you can look at to see what your hospital ratings are for a whole host of different things. Because Leapfrog is sort of a consortium of payers, the people who pay for healthcare. They tend to be huge, multinational, multi-state footprint employers. But when they give their ratings out, hospitals are really afraid to be on the bad side of those ratings. And so, there is power that you can wield to some extent as an advocate. I think particularly if you live in a community where the hospital is regularly failing, I think that's something you should bring up to your state reps, to your city councilman, whoever has sort of the levers of power there. And to the extent that you can get your neighbors involved, you'll be even more powerful because, one voice matters. But, if you get 30 people in a neighborhood to reach out to their city council person, you're going to have a lot more traction. So Brill brings up that the AHCA says that what they get from Medicaid falls $7 billion a year short of what they need to provide nursing home care, or $25 per patient per day short. That doesn't surprise me.
Yeah, well, I think we discussed that in broader terms, and that's really useful data to illuminate what we just said.
Yeah, and I think that that's something that, so there's this odd thing that happens, and I don't have the study in front of me, but I know that this is true, is that, Medicare, most Medicare spending happens in the last 3 weeks of a person's life. Like some huge disproportionate amount of the spending by Medicare happens when somebody is more or less on their way out, probably past the point where there's any meaningful hope of recovery. And so, when my grandmother had that stroke, we elected, because there was no chance for meaningful recovery, for her to be moved to hospice and spend her last few days there. And I think that that's another conversation that comes into patient safety, which is, what do people want done for them at that point? Because we're spending an enormous amount of money that I think is being spent because those of us who are adults and have elderly parents can't let go. We want every measure to be taken for them in a way that is probably not fair to them either. And at the same time, people who are alive in nursing homes are not getting the resources that they need when they could have meaningful quality of life. So it's the incentives are all off in terms of how we're spending money.
Right, and the allocation of resources needs public input. That really reflects our values and preferences, and isn't just the legacy of where money has gone for decades when we organized, or when our healthcare was prioritized differently. And it reflects a culture of medicalization that I mentioned in one of my slides, and doesn't shift to a culture of whole well-being.
And I think it also,
go ahead.
Well, I think it also, the medicalization aspect of it also focuses on you're sick, let's deal with you being sick, as opposed to how do we best keep you healthy. And one of the things that I think we've known this for a while, but one of the things I think is becoming clearer is that there are all kinds of impacts to our health that are not within our control as individual consumers. Do we live downstream from a polluter? Do we live in a city that has high pollution, so we have a high rate of asthma? Do we live near a Superfund site? Do we live in a food desert? And I think for, people like us who, are sort of well educated and have, good jobs and make a decent living, we're not facing a lot of those things, or we have the ability to sort of mediate them. But for a lot of people, they don't have that choice. And I think that, if we really want a healthy society, we have to look at what are the inputs that are giving us, that are giving us kind of a shocking amount of chronic diseases, many of which are preventable. But I also think that means that there is no resource for this kind of pandemic because we're spending all of our money taking care of people. And it's not, this is where we miss the boat too. It's like, it's not the individual person who has diabetes, right? Like, it's that we as a culture consume food that is going to disproportionately make people diabetic. And I'm guilty. I've had a lot of cookies since we've been stuck in the house for 5 weeks. And I think if we change that model from like, I'm a passive recipient of healthcare to like, I'm a citizen who wants us to all be healthy. Mm-hmm. And not because it saves money, right? Like, because like we should be healthy, So do folks have other questions or comments at this point?
I have a question for you, Christian.
Oh, please. Please.
So you're my case study of one. So I talked about insiders and outsiders in activism, and I often personally kind of waver between the two and think, can I have more impact if I am a well-behaved insider or a slightly badly behaved insider, but not to the point of being thrown out, versus being angry and staying on the outside saying, you need to do better, rather than we need to do better. How do you address this? Because you're a successful veteran, advocate, activist. How do you like to play?
So I, over the past 10 years, have met a lot of advocates, of patient advocates, and these are people who have been grievously harmed themselves by the medical system, who have lost a parent, a child, a spouse. I mean, things that are so unimaginable for most people. And, some of them never get past the yelly, screamy side. And yesterday was 10 years since my mom passed away. And, I faced it through our summit yesterday, but like, I'm hurting. I'm really hurting that she's been gone for 10 years. And I do get very angry. I get very angry about what's happening with COVID and the fact that we've been working on a lot of this stuff for years, and there was some progress, but not enough progress. And I get angry that progress either happens or doesn't happen because of who's in the White House or who's in the governor's mansion, as opposed to what's the best thing for the population. So, what I say to people who want my advice about whether or not they should be angry, I would say you should be angry, but you should be angry in a way that is productive, and I would say almost in a way that's cold, right? And so what I have tried to do, I'm giving my secrets here in front of all these people, but actually they're really not secrets, but, there's an Irish saying that the best thing you can do is, you want to have a manner that when you tell people to go to hell, you tell them in such a way that they look forward to the trip. And my mother was great at that. And then her dad, my grandfather, was great at that. And so, what I try to do is channel that anger into work, into hard work, into like building this foundation, building this organization, connecting with all these people across the country, connecting with you. And then, when I go and I'm in front of, if I'm testifying somewhere or if I'm in a meeting, like I try to like let it out a little, right? Like I try to be stern in what I say, or to speak in such a way as like I am a citizen, and I say this to us, to our advocates when we're doing lobby days. It's like, you have every right to be in their office. You have every right to ask them, even if you didn't vote for them. They represent you in the government. And so I think it's not so much a matter of being angry or not angry as sort of standing in your conviction, right? And if anger gets you there, then by all means. But So I think that I would say that we are still outsiders in many ways, but we have built good relationships with everything from our corporate sponsors to folks that work at CDC. I don't think the FDA likes me very much. Because when I went there in November, I was really angry. And I base it, and here's the thing that I really wish that people, that more citizens understood it. And this is, I think, another way when you think of yourself as a citizen and not a consumer or a patient. A lot of policy that gets made is not about science, right? Like right now, we're struggling from a shortage of testing around COVID. We're sitting in our houses because we can't figure out whether or not we have it or who has it. And so we can separate those people from the people that don't. And so ultimately, that's not a scientific problem anymore. Mm-hmm. It's a how do we fund the production of tests and get them where they need to be? But that's a policy conversation. Uh-huh. And so, even with something like C. diff, it's not a scientific question as to whether or not you give a child that may or may not have a bacterial infection. Like, you can do the test and find out if they have a bacterial infection or not. So it's not a scientific question. It's how do we get as many patients in and out of our clinic as possible in a single day, and giving them a prescription for antibiotics is easier than spending 20 minutes telling a parent how to help their child deal with the uncomfortability of having a head cold, right? And so, ultimately, at the end of the day, those are not scientific questions, and we should leave the science to the scientists, right? And I try to understand the science enough to be a good advocate and to surround myself with people, like Gerard Honig, like Marty Glazer, people that we know in common who do more the science side of things, whose opinions that I trust and value. But ultimately, when we're doing the advocacy part of this, we're dealing with questions that are about resource allocation, moral questions, ethical questions, who has power in a situation. And it's not necessarily about the science. And again, people people can get really angry about, big pharma or big hospitals, but generally it's the people who work in those places really want to do a good job.
I think one thing, though, around science, where we have a role as citizens, and I work in patient participation in research, bioethics, and so on, is we need to help scientists define the questions that they're then investigating. So
right.
they're the scientists, and we shouldn't be amateurs at that. But as citizen scientists, we could be in the room when they say what outcome they want their science to arrive at, or what is unknown and could be knowable. And sometimes those questions don't have us in the room, and they're just off. They don't really help what we need. They define our needs for us. So I do think we have a role in science, even though it needs to be a kind of a humble role.
Yeah, I mean, and you know this as well as I do, but I think for folks who don't know this is, historically clinical trials, we had a lot of talk about clinical trials of the last 3 days, and this is certainly changing, gotten better, but historically clinical trials were done on men. It didn't include women or people who were assigned female at birth, let alone maybe intersex people who might have a whole host of other things, but but then those medications would be given to women, right? Or they have clinical trials that are done on adults, and then the medication is given to a child. And so we don't have the scientific data around those representations. And that's for us as citizens, we should be saying, no, we want clinical trials that have as many people, that have a great diversity of people in them, so that we understand how that's going to affect a diverse population and not just white men who are young and healthy, right? And the other thing that makes me think of is, as a gay man, people always ask, well, how did you know you were gay? Is being gay genetic? Is it the way your mother raised you? And my whole thing is you're only asking that question if you want to figure out how to make it not happen. Or not necessarily, you know what I'm saying? why figure out the root cause of something unless you want to try to maybe change it? Like, if being gay is okay, then we don't need to know what causes it, right? It's not a more interesting thing than saying, like, why is Tara left-handed and Christian's right-handed? It doesn't matter, you know?
And I mean, that leads to a thought I didn't bring up, which is, of course, to bring your whole identity, or, you know, think about how your identity can help you tell your story. So we don't have to take those labels that I described. We don't have to take any of them. I was looking at the poll results, and a lot of people said something else or someone else.
Yeah, a combination.
So my ideas are more provocative, to kind of think about, what if you integrated a citizen identity on top of those very personal identities, because the personal is what leads to the stories, and the stories have more impact than anything.
Go ahead.
I'm just being mindful that our session time might be closing.
Yeah, we're nearly done. I'm gonna have to say goodbye. But so this is something that I think that folks can think of, right? So you asked how people identify, or who are the audience that we choose for our work. So those are really two important questions, right? But the other thing is that identities are social, right? Like, me being a gay man has no meaning if no one else identifies as a gay man, right? Or me being somebody who works on C. diff advocacy, like, that matters in relationship to my mother being somebody who died from C. diff. It matters in the ability to tell people I care about this issue, and therefore, if you also care about this issue, come and join me. So they're inherently social categories in some ways. And so why I think it matters, you know, there's the way that we'll choose to identify ourselves, and it could be some or all of those things that we ask. But if you're sitting in a waiting room in a healthcare facility, and the nurse or the doctor comes for you, they see you as a patient. Mm-hmm. And so I think we have to begin to think about, what does that mean? You know, am I signing paperwork that maybe takes away my rights as a citizen when I enter this healthcare relationship? When I put my loved one in a nursing home, are they signing away their rights? And so those are the things that I think, and this is why I really wanted, you know, you to have this session with us, because I think that these are the questions that we have to be asking ourselves, because we're never only one thing. And I think, to the extent that we could have the healthcare system look at us as citizens who have a healthcare need, as opposed to patients that are sort of passive recipients of healthcare products and treatments.
Yes.
So we're nearly at time. We still have 55 people with us, which is pretty good, I think, after 3 days. So Tara, I'm going to let you go. Thank you so much for being part of this. We will share your article and your deck with everybody. I think this is a conversation that we're going to want to continue with our Advocates Council members over time.